I would like to turn it over now to Lori Berrigan, just to give a bit of an overview of some of the process that we have been going through and where we are with that in terms of looking at exploring where we can move to in the future of clinics. Lori, the floor is yours.
Can you hear? I hope you can hear me.
We can hear you. Thank you, Lori. Welcome very much.
Okay, a little technical challenges, but here I am. So I'm very excited to be here tonight and have some people on the phone interested in what we're doing. Just as some background for those that are new to this, the Kootenay Boundary Divisions of Family Practice has for some time been facilitating an engagement process that's been exploring the potential appetite for a network of community health centers in our area. And we want to learn from other folks who have done this work before, who are directly involved with community health centers as practitioners, managers, advocates, etc. So this is the first in a series of 3 webinars, and maybe even more to come after that. The purpose being to facilitate some focused learning and discussion on different aspects of
Lori, I think you muted yourself accidentally.
Yeah.
Okay, where did I leave off? That just happened.
This is the first of.
The first of 3 webinars, and I think our focus is going to be to learn from others and have some discussion about different aspects of making transition into a community health center model and what's involved in opening and beginning this process. So we're happy to have several experts on the phone today or on this WebEx. The webinar today will focus on what transition might be like from private practice clinics to community health centers, and explore how we want to support practitioners in that change, you know, from a very business model, primarily fee for service, to becoming something that's bigger, and how we can involve community leaders and patients in a really meaningful way. So without further ado, because we've had a few little early hiccups, over to you.
Thanks, Lori. So our agenda for tonight is really just to have a chance to listen to our panelists. The focus is very much on a transition. So we'll have a bit of a structured dialogue. We have 3 speakers. They'll each have about 3 minutes each, and then we'll have some time for follow-up questions. I'd like to take a minute now to introduce our panelists. We're really pleased and really appreciate them taking the time to be with us today. Our first panelist will be Gray Schowler. He's currently serving as president of BC Association of Community Health Centers, and is also the transition lead at Island Sexual Health in Victoria, BC. Previously, he held the position of Director of Health and Support Services at Kootenay Community Health Center, so he has a long experience working with community health centers. And RN by training, Gray has really a multifaceted perspective on community health centers and team-based care. Our second panelist will be Christine Matuszewski. She's been very involved in supporting Team Excellence with Patient Society, or STEPS, which was incorporated in 2017 and recently opened the Orchard Walk Medical Clinic in Kamloops, a community health center that provides general family practice services. Christine brings her business background and acumen to her current role as the Executive Director for STEPS Community Health Centers, and is also the treasurer for the BC Association for Community Health Centers. So she'll be our second panelist. Our third panelist is Barb Marsali, Chief Executive Officer for the Washington Association for Community Health Centers, which supports 27 community health centers in Washington state, many of which operate multiple clinics and provide healthcare at over 300 sites across the state. So he'll bring a little bit different perspective, a US perspective. Their association helps community health centers recruit and retain skilled staff and provides a lot of training and technical assistance. So he's been really involved in supporting many private practices to make the transition, working with both physicians and community members to look at making the transition from private practice to community health centers. So we're looking forward to getting that perspective also. We're hoping that Dr. Selena Lowry may be able to join us. She has been instrumental in creating the STEPS Society in Kamloops. So if she is able to come in at some part of the webinar, we will draw on her expertise to hear about some of the lessons learned that she's experienced serving as STEPS founding president and board director and its current medical director. So with that, I would like to jump over and really start kind of our panel discussion. So I'll turn to you, Gray, and ask you, based on your perspective working in a community health center and advocating for community health centers at the provincial level, what do you really see as the challenges and opportunities for physicians and other team members and community actors in terms of moving towards this new and different structure and approach?
Great. Well, thank you for having me today. I really appreciate it. So very quickly, I mean, I think, starting at the patient level, access to team-based care, I think is a huge win for individual patients. And I think, one of the things that really differentiates the community health center model is that expanded programming around the social determinants of health and health promotion. So not only are you able to go there and get your medical care, but a lot of the other types of programs and supports that we know support health for individuals, families, and communities are usually integrated into those medical services. So kind of a more holistic approach, team-based approach. I think for communities, there are lots of benefits. One, I think, is that the model tends to be responsive, they're community governed, and so the nature of the programming, the service delivery model really reflects the needs of the community. And within that, are highly adaptable as things change, as demographics change, as certain health crises come up. They're able to be extremely responsive in ways that larger organizations may not be. And I think particularly for rural areas, the stability and the ownership of the community health center is really important. We know in rural areas, if a family doctor retires or moves or whatever, in many cases we have orphan practices. And when you have that community health center model, you see that stability. There is a team to absorb the patients. The community is responsible for recruiting additional providers, and providers want to work in community health centers. So it provides a little more stability. And then I think for the providers, there's tons of benefits and opportunities. It's team-based care. You're working in a team. You're drawing on the knowledge and expertise of different disciplines and different providers. You have a shared care and responsibility. It's not all on your shoulders. And I think, we know that lots of independent family physicians struggle with the administrative burden that comes from being a small business owner in a practice. And the community health center really takes that off of you and allows you to focus on providing patient care. It's up to the community health center to pay the bills, to do the overhead, to do all of those different things, find locums, and really you're able to focus on patient care. And, if you go in the direction of a salaried model under the ministry's directive around community health centers, you have compensation for non-clinical activities. So that hour or two that you're spending at the end of your day filling out paperwork is paid time, whereas a lot of those times in a fee-for-service practice, those aren't billable activities. And same goes for professional development and other activities as well. I think the challenge is obviously moving into a group practice. There's a loss of autonomy. If you've been used to running your own show, you're not always defining the patient population you're serving. And absolutely, there can be challenges in working in a team and having a shared philosophy of care. But I think those are things that are able to be dealt with when you have a good leadership around your team-based practice. So I'll leave it there for now.
Thanks, Gray. That's a great opening and a good kind of overview of some of the challenges and opportunities. Next, I'd like to turn to Christine. You've been so involved in just the last couple years in working to start up STEPS and the Orchard Walk Clinic community health center in Kamloops. What are some of the lessons learned, particularly in terms of kind of how you structured the business plan, that you can maybe share with us in terms of starting up a community health center?
Sure. Selena actually sent me a text, and she just sends her regret. She's not going to be able to make it. She's still seeing patients. So I just wanted to let everybody know that she won't be here tonight, but she any questions, she'd be more than happy to answer. And anybody can send me an email, maybe by Kate, following this to her. So some of the lessons learned about business structure, board compensation, communications. I would say that in the beginning, our bylaws were created and purposely we had a composition of board members, including a lawyer, an accountant, an Indigenous representative, a fundraiser, and 2 healthcare professionals. And that was really instrumental in guiding some of the foundational framework pieces from a business perspective. Organizational structure, we've been in operation for 2 years, and we're just kind of landing on an organizational structure that enables physician decision making to happen really clearly. And when we've been sorting out how and who makes decisions. And so I think when you're starting something out, you need a mechanism that's really strong in bringing everybody together. We have a clinic manager who is instrumental in our success around communications, purchasing and ordering, IT. Those are some things that were big hurdles for us to overcome. Also, I think in developing your strategic plan and how you're going to approach your community health center in doing all the work that it takes to form a community health center, I think it's really important that you have some upfront conversations about, you know, what kind of culture do we want to have? How do we set that culture? Early on, we said, you know, we want a fair culture. We want unparalleled patient care. We want kindness and compassion and empathy. There was some cornerstone words and philosophies that we drilled home on, and that has carried us through some really difficult and challenging conversations around how are we going to do this together? You know, even the team development, who's going to do what and what's that going to look like? Sharing patients, like what does that look like? And building team and adding team members. And so I would say that there's some fundamental pieces and forethought that need to just go into around how are we going to do it and who are we going to do it with, and what does that structure look like? Because I think we definitely jumped in and we didn't necessarily realize the importance of those foundational pieces. So happy to answer any questions around any of that. Certainly lots of learnings.
That's great, Christine. Thank you so much. I appreciate kind of the recent experience that you're sharing and some of those practical areas in which you were able to share what you're working on. Next, I'd like to turn to Bob Marsali. Bob, you have supported many practitioners and communities to make that transition from private practice to a community health center. What would you advise practitioners and community actors to consider as they contemplate making that shift?
Sure. Thank you, Kate, and thanks, Christine and Gray, for your initial remarks. I'll probably echo some of what you have said based on your clinical and professional experience. You know, I think moving from a private practice to a community health center model of practice is a little bit like becoming a parent for the first time. And you think you know just what you're supposed to do until you have a child in front of you. So there needs to be that first step of realizing that it's a journey and there will be mistakes that will be made, and even with the best laid plan. So I think that's one important thing that I've counseled folks who are interested in becoming a community health center here in the state of Washington, and before that in Montana and in Oregon. You know, one of the things I always ask people when they start this journey is, what is it that you're trying to accomplish? What is your motivation for wanting to do this work? And a colleague of mine likes to put it this way: what is your North Star? And I think to Christine's point about culture, what are your mission, vision, and values statements going to do to help you not only move together in a single direction, but also be guardrails for the way you do that process from a private practice to a community-based clinic practice. I also encourage folks to make room for what they're going to leave behind in that transition, and what it is that they want to bring forward in a culture of excellence, of patient-centeredness, of team-based care, of clinical quality. So those are some things that I suggest. Another, I think, for the practitioners in particular, is what does it mean to move from ownership to being an employee of a practice with a community majority board as your bosses, with a CEO as your boss, who has the authority to not only hire but negotiate your salaries and God forbid fire you. So I think being prepared to mentally to make that transition from owner and director to employee it is a tricky one, and shouldn't be underestimated as far as the stresses of that. I think consideration needs to be given early to how you want to pay and what do you want to be paid for. So thinking about your practice from the payer's point of view, and how can you organize yourselves in such a way that you're being paid for what it is you're hoping to accomplish, remembering what your North Star is, and negotiating contracts that help you to get to that place where you are putting the patient first, you are putting the patient's health first. And finally, I think I would say to Gray's earlier remark about the social determinants of health, really being conscientious about how are you going to capture and measure those in your patient interactions, and of the myriad social determinants, which 2 or 3 are you going to focus in on as partners with community-based organizations to address the whole health of the population that's attributed to you and to your care team. We've learned, sadly, through the pandemic in the United States, much about the social disparity of the disease in communities of color and of poverty. And it has really focused us once again on social determinants, not as an academic exercise, but as an existential one that community health centers in the state of Washington and nationally really need to roll up our sleeves and to address. So I'll stop there, and thank you for the opportunity to be with you today.
Thanks, Bob. That's some really important issues to be thinking about. I'd like to kind of build on what some of you have said and toss a question out there that we haven't fully addressed yet, but I'd be interested to hear from you what role you see that community members or communities can play kind of specifically in supporting or helping with this transition. And I'll put it out there for all of you and see who would be most interested in tackling that first, and you may have some different perspectives on it. So what role do you see for community or community members to play that can really help facilitate this transition?
Well, I'll take a crack at that quickly, if I may.
Sure.
I think as just a method of practice in the United States, when you are applying to become a community health center and receive the grant funding from the federal government to do that, one of the things you need to do is a community needs assessment. And I think, so having some sort of structured way, whether formal or informal, to solicit input from members of the community to determine what it is that they think that they need, and creating from the get-go a shared decision-making model where you're engaging folks and redistributing the power so that you as the clinician aren't dictating to the community what they need, but you're leveling the playing field so that they have a role early on in shaping the programs that are top of mind for them.
Thanks,
That's
Bob.
interesting.
Go ahead. Did you want to add to that, Christine? Please do.
Yeah, I'm just thinking about our like STEPS experience so far, and our work with Division of Family Practice. There's been, through GP for me, there was a bunch of community engagement and assessment. Over the last little while, our division hasn't entered into the PCN, but we moved ahead and developed, created, implemented, operationalized our community health center. And what we're finding is we have a lot of analytics within our EMR. We have about 7,500 patients, and we're still accepting patients. And so we have engaged the practice support program. We've also engaged SIPSN. We've also been in touch with a few people, including the Kootenay Boundary, around evaluation and quality improvement frameworks. And we're really trying to understand what our population looks like. So we have this 7,500 people, and what are their needs, and where are they being referred, and how do we support them? We've just started implementing the Health Myself portal, and we're really curious around how do we engage the patients, maybe through surveys and interaction that way. We haven't done a lot of engagement with our patients to date because we're fairly new and we've been just adding providers. We've grown from 3 full-time family physicians to we now have 7 to 8 family physicians, a nurse practitioner, registered nurse, diabetic educator, dietitian, respiratory therapist, and we're just recruiting a social worker. And we are on the fee-for-service model, and we do access grants for some of our work. So it is an interesting thing around how do you understand and resource what you need? How do you understand the health human resource planning from a local and a regional and a provincial perspective? And we're really kind of to trudge through that and trying to figure that out. And maybe Gray can speak a little bit more to that, but it's definitely a work in progress.
I would just add too that I think community, I mean, obviously when you're starting out, you want to identify, what you need to do to benefit the community and what are the community needs, but community is really an ongoing part of a community health center as well. In my time at Kool-Aid, we had community members that were peer leaders in our programs that helped facilitate some of our programs. They provided feedback. And they were an amazing resource, and they just helped to leverage that kind of core clinical team into something even broader. And people often want to learn about their health and participate in their health with people that are like them. And so bringing community in and having, sharing some of that power, but bringing them in and having them be part of your service delivery model can be amazing, and really encourage you to think about ways that you can do that on an ongoing basis. Give an example. We have a low barrier exercise program for people with mental health and substance use programs. We had that at Kool-Aid, and that was entirely, we had one paid staff member that kind of facilitated, but it was peer run and volunteer run. And, a program I think is 12 or 13 years old now and incredibly successful. And those are the types of things that you can do to leverage those community resources.
Thanks, Gray, and thanks all of you for commenting on. There's a lot of really exciting ways I think that community can be involved based on what you've been sharing. I wanted to dive in with one more question from me before we move to open it more to the floor. And that would be, several of you alluded to the challenges that physicians face as kind of that key aspect of shifting from private practice to a community health center, and the fact that there's many benefits to that, but it also is, I think, kind of quite a scary prospect for many people. And just if there's any kind of quite practical advice in terms of, one or two key things to sort of think about in terms of making that shift from private practice to a community health center. Just drilling down on that a little bit. Would any of you like to tackle that one?
Yeah, could I just, I think I'd just start off, sorry, before jumping here, just because I think it's one of the things when we have this conversation is to think about what the model is in terms of compensation and the relationship for physicians. So currently in BC, there's a couple options. One is you could have a community health center and work within the fee-for-service model, which is what most community health centers are doing right now because there's a limited supply of contracts. If your particular community health center was looking to become a community health center kind of under the Ministry of Health policy, then you're able to access those contract physicians similar to the PCN and the UPCC contracts. So those are the primary care network and urgent and primary care contracts. Most times when you do that, what happens is the physicians sign a contract with the community health center to provide services. So they're not signing it with the health authority. So I just think when you're talking about that, it's important to understand, kind of which direction you want to go in terms of that. And then obviously that structures the relationship a little bit differently. So I would just make that point before the other panelists kick in.
Thanks, Gray. And I think at this point, we're still kind of exploring options and not sure exactly how it may be structured in terms of financial and compensation, but that's a good piece of information for people to have. Would others like to tackle that issue in terms of just kind of, I think you alluded to it a bit, Bob, in terms of that is a ceding of control, which I think,
yeah.
What's the compensation in the sense of ceding control, but what are the benefits that come with that, and how can we support people to kind of work through those issues, physicians specifically?
So I think clinicians have a lot more power in a community health center than perhaps sometimes they even recognize, because if you don't have clinicians working for you and feeling good about the work that they're doing on a daily basis with and for you, and especially for their patients, because that's their ultimate concern, you're going to have nothing but trouble. So I think while there are administrative requirements that the executive director or clinic manager has to face certain realities in terms of cost containment and eliminating waste and so forth and so on, I do think that while as a clinician you may not have a lot of say anymore on what's purchased and what's not, you have a lot of influence on the practice from your perspective in terms of the direction that the practice is going in. So I would suggest to clinicians who are a little bit nervous about that transition that you might be giving up some structural administrative authority, but you still have a great deal of influence on what the practice does and how the patient is encountered in the practice and the tools that are used to serve the patient.
Yeah, so it's thanks, Bob. That's really great. It's really good. At STEPS, our providers, they are the ones that really drive patient care and clinical and medical decisions. Our board and our administrative team really do everything that they can to support that provider-patient relationship that's going to result in the best patient care health outcome. That's kind of our everything that we do focuses around that relationship, that outcome. What our providers have said, we've had a few who have had private practices. We have had a few that are IMGs that have done their 2-year return of service with us. We have a PRA who's just finishing up their 3-year return of service and joining us. We have residents, medical students, we have nursing students, 3rd and 4th year nursing students, BSN students, we have nurse practitioner students. We have a lot of training and learning that goes along with our site. And what we've heard specifically as being the benefits to physicians who have transferred in is being able to be away and we have locums knocking at our door. So being able to be away when they need to be away for whatever reason, a sick day, whatever else, we are almost always able to provide coverage. Financially, we're able to utilize the space, and so it lowers the cost of things, and we do a fee-for-service split. So there's some financial benefits to not having a space and having fixed costs, especially in these COVID times. It's been quite an interesting transition from all in-person care delivery to a virtual in-person model where we have had quite a few other providers, other physicians knocking on our door asking if they can join us for a multitude of reasons. Patient coverage, so when people do need to be away, there are other providers and there's locums that they're happy to fill in. And we early on decided that one of our measurements of success was enabling patients to book an appointment within 3 days. And we've been largely successful. We had no patients when we started. And so we've attached 7,500 patients in 2 years. So that patient coverage, what we found is as we were adding patients, all of a sudden there was like a three-week wait. So to get into a certain provider. So we were able to do first available appointments. The other thing is fit-ins. So if there's a baby that has a fever, if there's an emergent need or an urgent need, not an emergency, emergencies go to Royal Inlet Hospital. But if there's an urgent need, the provider who's the primary care provider is asked if they can see that person. And if not, it goes out to the entire team. And very, very rarely do people end up being sent to emergency or we can't get them in. It's very, very rare that ends up happening. So access to care has been something that's been a benefit, and our providers have really appreciated because they're not worrying that somebody might not be cared for when they really need that immediate care that day. We have a critical mass of providers who are able to help out and do that work, and that's been a really positive thing that our providers have identified. The resilience, I think, as well. So we have an administrative team, we have the technology, we have Med Access, we have Business Connect through TELUS, and going virtually and adding staff and growing our team. That's been something that we've been quite proud of because we've been very successful in making sure that we have everything in place to do what we need to do, especially virtually now. And that's been really successful, and our providers have really appreciated, going home and then all of a sudden having eFax. Oh, that's great. Like, I can do that right now. That's really helpful. The other thing too is hiring staff. Our providers are pretty happy not to be hiring staff and managing, and when somebody's sick, them not having to worry about that and know that their tasks are going to be done and their patients are going to be looked after. One of the other things I think that is that with the staffing and resourcing that we're able to do, because we have that critical mass, is we do have MOAs on 7 days a week, regardless of if there's people in the clinic or being seen. And so tasks and things are being done kind of all the time. So those would be the wins that I see off the top that I'm hearing fairly regularly.
Thanks, Christine. That's it's good to hear all those positive things. Gray, you typed in a comment into the chat box, but maybe you could just briefly share that with the rest of the group, and then we'll wrap up my questions and move to questions that have come from the audience.
Sure. I was just saying that, I mean, in my experience, that it's, it tends to be very collaborative in terms of the decision-making with providers, physicians. It's, I think, and as Bob said, if it's not a place people want to work, then they don't have to work there. There's lots of demand for physicians, right? So I think it's incumbent upon the CHC to have that environment, and most of them do. I mean, I think getting back to what Christine and Bob were talking about in terms of that shared vision, I mean, if everyone has that shared vision and they all believe in good quality patient care and you're working towards the same thing, then that, that really creates an environment for collaboration and working together. I don't see CHCs as a place where it's the employer and you show up and you kind of punch your card and you don't have an input. It's a place where everyone's really actively working together to make things better all the time. There are certain things that are non-negotiable. You have deliverables in terms of your hours of service, and you have to see a certain amount of patients. And I mean, that's the reality and those are the realities of running primary care practices. But within that, there's lots of flexibility and adaptability. And my experience is that providers are very much involved in shaping the practice.
Okay.
Can I just add one more thing? I'm just thinking about our model. We do provide, we do fee for service for the most part, but we did try a base rate of pay with fee-for-service in the background to begin with. And if anybody's curious about that, I'm happy to provide some information around that. The other thing that we still do is we have one physician who provides gender affirming LGBTQ2+ and transgender care. And we do access grants because the fee-for-service model just doesn't sustain the billings to be able to do that work. So I'd say the other thing that community health centers are amazing at is innovating to meet the needs of their population. You know, where there's a will, there seems to be a way with the folks that I've met.
Yep.
So.
We've got some great questions that are coming up in the Q&A box. Andrew, I'm going to turn it over to you just to kind of moderate those questions. And also open it up to the rest of the audience. If you do have questions for our panelists, please do type them into the question and answer box. And then Andrew is going to be kind of collecting those and directing them to individual panelists or the panelists as a group. Andrew, the floor is yours.
Okay, thank you. Well, this is a challenging assignment because the questions are great, and you know, some of them are sort of been answered, but then there's nuance in them that we could go deeper in. So I'm going to do my best to kind of moderate through this. There's a bundle of things around the other services that are integrated in the CHCs, that fuller story of what primary care looks like. So this first one is directed to you, Gray, but I think others could probably wade in on it quite quickly. So, you know, within the BC context, typically what other services do you see in community health centers? So that's the first question. That one has a bit of a sub sector. And I know it's coming from some of our local conversations are that we would like other private providers like physiotherapists or chiropractors or whatever, maybe a pharmacy to join the community health center umbrella. And so the sub question is, how do you deal with perceptions around competition? You know, giving certain private providers, you know, a special leg up in terms of access to or whatever else. So I'll start with you, Gray. You know, what do we typically see in terms of the mix of service provision, and then just a little discussion around that introduction of private providers. And I'm looking forward to Bob's addition by the smile he had in his face when I raised the question. So.
Sure. So in terms of the other types of programming, it actually varies really according to the CHC, and that's, you know, the beauty of the model is that the breadth of programming reflects the community, and community means different things in different places. They can be geographical, they can be communities, you know, that are defined by shared characteristics. So for example, newcomers to Canada, or mental health and substance use people that are struggling with those issues. And so often the types of additional programming around health promotion and the determinants of health are tailored to the needs of that particular community. And I could give, you know, different examples. So Umbrella Multicultural Co-op, which is in urban Vancouver and serves newcomers, does a lot of things around navigating the healthcare system and providing language services and support groups to newcomers. If you look at Pender Harbor, which is on the Sunshine Coast, they have a large seniors population. So they have, they do an adult daycare program where people are able to drop a loved one off for part of a day and do some programming there and participate in some health promoting activities. You know, at Kool-Aid, as I talked about, we, you know, exercise and diet programs for people that are living in poverty. So all of those things are possible depending on what the need of your community. The thing about a community health center too is that you're able to leverage different types of funding as a non-for-profit. You can write grants. You can open social enterprises like pharmacies, for example, to create additional revenue streams to support different types of programming. So housing tends to be a big piece. Looking at a multi-ministry approach where you might have people from the Ministry of Poverty Reduction and Social Innovation coming in and working with your clients around income entitlements or access to housing. So it really depends on the needs of your community. Yeah, I'll leave it at that.
Thanks, Gray. Bob, did you want to weigh in on this one a little bit?
Sure. I think in the United States, the question of an unfair competitive advantage does come up from time to time, especially in dentistry. in large part driven by the fact that in the US, especially with regard to our Medicaid program and population, community health centers receive a cost-based reimbursement structure that is far more lucrative than a private provider receives from the Medicaid program and their fee-for-service schedule. But as far as services offered, and because of our close relationship with the federal government, health centers are required to provide directly or to contractually provide for not just medical care, but also dental and behavioral health care, now substance use disorder care as well. Some health centers in the US and in Washington in particular have their own in-house pharmacies that they operate. And we have a smattering of health centers that also offer optometry services. No chiropractic medicine, but naturopathy is not an uncommon service that is provided by a few of the community health centers here in Washington. And so I think, you know, just as Gray was mentioning, a mix of services that really addresses the needs of the community, because at the end of the day, the health center does belong to the community in which it is located. A lot of mobile service is being offered here, in part because we have such a large agricultural community, and getting out into the fields is of a high priority in some parts of the state. So I'll stop there.
Thanks, Bob. Christine, I'm going to take you're still being on mute as a clue, and I'll just maybe jump to the next question, but jump off mute if you wanted to chime in.
I think Gray has a really good perspective around what the composition of different community health centers around BC. Steps we have really taken our cues from and looked at our population and our unattachment really in our area. Kamloops in our area had over 30,000 people who were unattached in 2013, I think. And so we implemented the BC Health Link, or whatever it is, the patient 811 list very early. And that's how we've attached patients. But also our providers had subspecialty. Some of them had kind of specialty interest areas like the transgender, LGBTQ+ population care. We have a physician who also does some care at 2 of our Indian bands close by. So she goes out and we utilize our EMR, and we've trained one of the MOAs at the band to be able to work with us. So that's some interesting work that we've done. We've done some work with Ask Wellness patients, so substance abuse, with access, and the fee-for-service model is really challenging with that, because as everybody knows, that population tends to not show up, or you know, you end up having somebody else who comes in, or you know, for a variety of reasons, that was a little bit more challenging. But I think every CHC, I think about Sun Peaks, they serve a really interesting transient population. I think every CHC's purpose is really community focused and does fit a need. And I really liked when Bob talked about, you know, what is your North Star? And I think providers have a really good idea often of what that North Star is. And that's how Steps became that, really. So I'll leave it at that.
Thank you. There's been quite a few questions about the issue of attachment. So Bob, for your context, about 1 in 8 British Columbians who would like one does not have access to a longitudinal primary care provider, nurse practitioner, or physician. So that's a major issue for our health system on multiple layers. First, of course, for the struggle those patients experience, but also for the sustainability of the system. So there's been a number of questions around how can the community health center movement, you know, does it address attachment? I wonder if, Gray, you mentioned that a little bit in the chat, but maybe you could start that one off, and then lead into it. Christine, there was a specific question for you. You know, did you open because of attachment? So let's tackle that one. See where we go.
We actually opened because of physician recruitment. So attachment is obviously they go hand in hand. So there was not enough family physicians in private practice here. We also found in community private practice, we also found that our residents who are graduating were preferring to do like hospitalist work and locums and things like that, and they weren't wanting to commit and go into owning and operating a business. And so that has that was really why our community health center, was started. And it was started from work that was done by the Thompson Region Division of Family Practice through a GP for me in creating an incubator model. And they came up with a business plan called the Multi-Physician Team-Based Business Plan. And that's how our STEPS business model kind of was developed. That was a starting stone and a cornerstone to the work that we started to do. And so Dr. Laurie has been working on this. I've been working on this for really since 2012, 2013. And so operationalizing in 2018 with all that work already done is really helpful. And I've shared my business plan with the Kootenay Boundary, and hopefully it's helpful. And I'm sure that the Thompson Region Division would be happy to share that as well.
So I would add to that, just in terms of attachment, I think that, as Christine said, community health centers are attractive places to work, and people that might not otherwise consider having panels will come to a community health center and have a panel. During my time at Kool-Aid, many of the doctors that we recruited were hospitalists, were new graduates, or recent graduates that didn't have practices, and with their experience working in the community health center, doing locum student placements there, they saw the value in that and ended up taking on panels. I think the other piece of that is the use of the broader team. So, again, going back to my time at Kool-Aid, in any given year, probably 40 to 50% of our patient encounters were not with a physician. They were with a nurse or a counselor, physiotherapist, dietitian. And so there are lots of parts of supporting people's primary healthcare needs that can be done through a broader team. And so you're able to amplify the effect of the primary care provider through that highlight of health. And in many cases, those other providers may in fact end up being their point of contact, depending on what their primary issue is that's bringing them to the community health center. So I think in those two ways, it supports attachment. It's not a magic bullet. I don't think community health centers are necessarily going to, solve our problem in the province all on their own, but I definitely think there is a benefit to the model.
Well, I'm happy for Washington State that you raised your eyebrows when I told you the numbers of unattachment. Perhaps things are not as grim south of the line.
No, I think most of you all, and perhaps those in the audience, are aware of the dysfunction of the American healthcare system as it relates to payers and access and coverage, and we're still, struggling with that. I think we would define attachment as attribution through a managed care organization or arrangement, which again may sound strange to Canadian ears. But even if a population of patients is attributed to a community health center, it is not uncommon for as many as 30% of that population not to have connection with a provider. So there's a lot of time and energy spent in outreach, in large part because of the contractual relationship with the managed care organization, so that unless certain quality benchmarks are met or exceeded, there aren't shared savings that are distributed that are financially advantageous to the practice. So it's both a concern for the care of the patient who hasn't been brought into care yet, but who the health center is responsible for providing that care. So that is not a problem that we have solved by any means, but through technology and some very diligent, hardworking outreach staff have closed that gap, some more successfully than others.
There's a question here around patient complexity. And in our environment, Community Boundary, we're perhaps a little unique from many community health centers in that our conversation is about serving the entire breadth of the population, not any particularly high needs groups. But so with that context, the question is, does the CHC model, how do you distribute patients between providers? i.e. does one provider not have a disproportionate number of patients with more complex medical needs, that kind of thing. So I'm just wondering how that works amongst the team.
Do you want me to tell you what happened at STEPS?
Yeah, you have the biggest grin, so absolutely.
Yeah, yes. When we started, we had no patients, and very soon after, there was a physician in town who was retiring. So we took on that panel, and what I guess seems to happen is that panels grow as physicians kind of go through their career, and so it was a more complex panel, and there was definitely more complexity there. Then we also went to our 811 list, and we said, okay, we'll take 100 people every few days. We'll phone. We'll get the list. We phone the patients. We intake them. We didn't really have any population requirements other than geographically. We wanted them to be within the eastern area around us in Kamloops, and so we did that. What we found is that there was definitely complex people right off the hop, like lots of complex unattached people, lots of people who hadn't received care in a long time that needed a lot of support. We also had new to practice physicians primarily working with us, and so we had a lot of learnings around that as well. I think after a little while, we also have the obstetrics group, and so we ended up taking on mums and babes as a population that we wanted to take on because we wanted to kind of balance the complexity. I think with the 811 list, there is the ability to take a look at existing conditions or their triaging, and so if you're looking for a more balanced practice, you can take a look at that. But what we did find is there is one physician who ended up with a little bit more complexity because that's what he was really interested in. We ended up with a physician who was really interested in kind of more of the mental health stuff. So she ended up with a little bit more mental health stuff. We ended up with a physician who was really interested in moms and babes, and she ended up with a lot of moms and babes. I think it just ends up being a team discussion. Like our MOAs kind of figured out what the preferences were of each provider, and kind of by osmosis, biased or not, or purposeful or not, that's kind of how it developed. I hope that's helpful in answering that question.
Yeah, I would add, I think it's a flashpoint. It's something to be attentive to and managed. I think to Christine's point, providers enjoy and find deep satisfaction in addressing the special needs of some patients. And so having room in the assignment of patients in the health center or across sites is an important feature. I also think, though, that as you structure your contracts with your individual providers, if they're weighted too heavily on numbers of visits in a particular day or a session, and that provider's panel is inordinately complex compared to her peers, there's going to be some friction there. So balancing how the contracts between the provider and the health center are structured for purposes of payment or purposes of awarding performance or meeting quality goals has to be taken into consideration as far as assignment is concerned.
All right, thank you. I'm just noticing our time, and I think we have 10 minutes left in our scheduled slots, 10 or 15. I just wanted to put it out there that for anyone who's not comfortable using or hasn't found the question and answer interface, first of all, it's at the bottom of your page under Q&A. But second of all, if you also click on, I believe, in the word participants, there should be an opportunity there for you to raise your hand, and we can certainly turn the mic on for any of the attendees that wanted to ask a question directly, and we'd be happy to make space for that. There continues to be, you've spoken all of you on the involvement of community and how you make sure CHCs are in alignment with community needs. And there's still lots of questions coming up on that. I'll pick on a specific one, but feel free to riff off it any way you see fit, because this is obviously an issue of great interest. And the specific one is how to engage community members in the governance structure. And I'll just provide a little bit of context in that our conversations have been about having governance structures that include providers and community members. You know, many community health centers only include community members. So anyway, just that little bit of context, which you can take into account or not, but fundamentally the question is successfully tips and tricks to involve community in governance.
Well, I'll jump in very quickly because it's pretty easy in the United States. Your federal statute, it's in the law that the board must be a community board representative of the population served, and that the majority must be consumers of the healthcare provided by the health center. So it is a non-negotiable for as far as community-based, community-involved, community-run governance structure. So I'll stop there, and I don't know if similar requirements exist in British Columbia and Canada, but that's how that works here.
So I think in British Columbia, I mean, community health centers are relatively new in terms, I mean, they've been here for 50 years, but in terms of kind of being under the ministry's policy and kind of being formalized, I think there is room for discussion around, you know, what the boards look like. I think, you know, I think the philosophical underpinnings is that it is community governed and that you would want a majority of the board to be from the community and not the providers. Otherwise it's provider run and it's not a community health center. So it's an important distinction. I know that in community health centers in other jurisdictions in Canada, they do have providers that are on the board. I think there's variations about whether they're voting members or non-voting members, and, you know, kind of getting into the minutiae of the governance. In terms of attracting community members to the board, and I think that can be an issue in some communities, is finding, especially at the outset, I think once you're up and running, you know, it's easier, but how do you get that first board going? And, you know, possibly looking around to organizations that are already doing related work that, that might share a philosophy as your organization and seeing if there's some interest there. Do you have people in the your local patient voice community that might be willing to step up? I think, you know, it's worth looking at the municipality and the role of the municipality. Is there somebody there that might be on the board? It's great to have those connections as well. I think there's room for flexibility. There's no mandate in BC that it has to be a certain number of people or whatever, but in the end, you know, I think the voting majority at a minimum has to be not providers. That makes sense.
I agree.
Christine, what was your journey to establish a board, starting from scratch? Was it all unicorns and rainbows? Just everyone came together and had all the skills and got along really well? And
all unicorns and rainbows. Yeah, we had Dr. Selena Laurie, who was the founding president. And early on with our Division of Family Practice, we identified some key community people who would be really, who were thought to be really instrumental in developing. So we had a PhD nurse practitioner, we had a business person, Indigenous person, a fundraising person. I think that was the composition. And then early on, also, they recognized that an accountant and a lawyer were going to be instrumental as well. So that's how we've built it. It's really, I think, important for whoever those board members are to understand that there is a clinical and medical responsibility that has to be supported. And that is one of the cornerstones to developing a community health center and making it sustainable and great for everybody to work. I think I think that having people who really value teamwork and kindness and fairness and with a lot of grit and gumption, because it takes a lot to start a community health center. It is not easy, and there's lots of hard, difficult conversations and lots of mud that you have to tread through. Is it worth it? Yes, I'm still doing it, so it must be. But it is challenging work. So I think the board members that you choose need to be ready for hard work and kindness and commitment and just a lot of grit and gumption, and experts in what they bring to the board and what you're needing from them as professionals sitting around your table.
I would just add too, if I may, that that great care and attention, to echo what Christine and Gray have said, great care and attention to the composition of the board. I would be nervous about too many providers on a board, to be perfectly honest with you, because as a lay person, it's easy to defer to the judgment of a clinician. That's what consumers of healthcare are trained to do. We're not trained to be in a shared decision-making role with providers, not because our provider community is totalitarian in any way, but their training lends itself to a perspective that sometimes can even be intimidating to a lay person. So I would urge caution in not stacking the deck, if you will, and great thought to governance, both in terms of, to Christine's point, it's exhausting and complex and difficult, but also because with great power comes great responsibility. And at the end of the day, it's that board that is the steward of the mission and the resources of the community health center.
I wonder if any of you could comment on the experience of community health centers in very small locations. So in Kootenay Boundary, we are 80,000 people, but spread between almost 14 municipalities. A number of our existing clinics serve populations of 1,500 to 2,000, sometimes even smaller than that. And those tend to be our more vulnerable clinics, as we've seen by the fact that a health authority is actually now providing primary care in many of those kinds of communities. If you have any insights to what scale means to this conversation.
I work very closely with Laura Bantock, Dr. Barkley, and Dr. Bantock up at the Sun Peaks Health Center, and they're a very small community. But then in the winter, they grow to like 20,000 or something like that for Christmas. Wow. And so they have a very interesting. They have a very interesting population, because they have their set year-round population, and then they have the transient population. Mm-hmm. And their municipality, they purpose-built a space for them, as well as right next door to the first responders, the ski patrol. And so I know that they do have, there are challenges there with the financial viability. They are on a salary or a base rate of pay type model. They don't do a fee for service. And so I would encourage anybody who's interested in a smaller place to get in touch with Dr. Barkley, Dr. Bantock, and Laura Bantock, because they would be able to speak to the first 2 years in operation. They operationalized around the same time we did, and there's lots of learnings and insights into what they do. So it's not easy. I think STEPS has kind of tossed around the idea of a hub and spoke type model, possibly like a not-for-profit partnership with providers in their clinics as well. That hub and spoke model, a model where we had a partnership between our not-profit and a co-op. And so I think that there's different business models that should be considered. And I do think that there's a way to do that really well while utilizing everybody's and well, optimizing and utilizing all the resources of a possible community health center. Because I often think, and we've kind of started to having conversations about this, especially with COVID and as we're growing and we're kind of running out of space, you know, where are our patients located geographically within Kamloops, within our area? And does it make sense for us to actually be renting, you know, an office space from one of the primary care providers, one of our family physicians in our area, and for one of our docs or our providers to be going there and us booking in with our EMR and sending a laptop and doing care that way? So I think that there's some interesting business models that that might be helpful.
Yeah, I think it's just a struggle. Small rural health clinics across the country in the United States are really struggling at multiple levels. I think that there are economies of scale. So what I've learned from Kate in our brief conversations sounds like a sensible approach, so that you're really conserving scarce resources, and you know there's strength in numbers.
Yeah.
And I think if I look at Ontario, which has a very strong community health center system, and in the rural and northern parts of Ontario, the community health centers tend to be this model. You see lots of them that are multi-site and serving communities, and then, you know, pooling their resources in terms of administration and things like that to create some efficiencies. Transportation, of course, is an issue in rural communities, and so you'll see mobile clinics going out, for example. So a team of providers going out to different communities 1 or 2 days a week and providing service there, so they're not having to pay rent and set up administration in those communities. It's not ideal, but there are different ways to do it. But I do, you know, to echo Bob, I mean, I think what's really appealing about your model is, you know, that ability to pool resources on some of the back end stuff in terms of administration and different things like that, and then be able to spread the provider resources out across a broader geographic area.
Great, thank you all. I'm going to hand the mic back to Kate to wrap our time up. Thank you in particular for all the attendees who've put questions in. For those that didn't get answered, I think they will be tackled in future webinars, so please sign on to those as well. Kate, over to you.
Thanks, Andrew. Huge thanks to our panelists. I feel like I've learned a lot, and also just, I think, had some really important points to think about. I think some of the key points we've covered are really the community role and different ways of partnering with different community actors. We had some interesting points on governance and definitely some key points to think about. And I think you've been really honest in sharing with us that there's certainly challenges in making the transition to a community health center. But I also appreciate, you know, all the opportunities that you've shared with us and some of the real benefits in terms of patient care and provider satisfaction, and the opportunities for team-based care, and really, I think the value of really having that community engagement and baking that in from the beginning, as Gray was saying, or Bob, in terms of talking about using a kind of a community assessment to really look from the very beginning in terms of what communities need and want. So there's a lot for us to think about. Our next webinar will be on Friday at 8:30 in the morning. That one is going to be focused more on team-based care and how we can use community health center to really advance team-based care. So we hope that all of our attendees and perhaps some of our panelists will be able to join that also. Before we wrap up, I would like to ask Leah if we have an evaluation for you to do, which will be, it's popped up now, which will be, if you could please fill this out, it would be very, very helpful for us. I think there's also one question which she's going to pose into the chat box. This is really helpful in enabling us to improve these webinars. We did have some technical challenges in this first one. I apologize for that, and I appreciate very much your patience. So if you can fill that out, that is a huge help to us. As I said, our next webinar will be on Friday at 8:30 in the morning. Please register for it. We'll send out an invitation. Please register for it, and I hope you can join us. The following webinar will be focusing a bit more on practical aspects of governance and finance, and that will be next Wednesday, the 15th at 12:30 in the afternoon. So thank you very much, panelists. Really appreciate your sharing your time and your insights and your experience and wisdom. I think I'd like to close with, I think it was Bob's thought about the importance of having a North Star. As we move forward, I think what we're trying to move towards is identifying exactly where our North Star is, and looking at how we can really use that as a way to guide us in what we're trying to learn and where we're trying to go.
Thank you.
So with that, it's 8:15. We will close. We'll let everybody complete the poll, and then we will wrap up.
Thank you very much.
Thanks, everyone.
Thank you, Bob, Gray, and Christine.
Sarah, good luck.
So long. Good luck.
Thanks. I'm sure we'll be in touch with all of you. We have more to learn.
Okay.
And if anybody's interested, please feel free to reach out directly. If any physicians have any questions, our physicians are always happy to engage. So if anybody has any questions, please do reach out.
I'm sure we will be contacting you, Christine. So thank you. And this has been recorded. So for anybody who was not able to attend in person, we'll be posting a recording of the webinar on our website, and we'll be sending out information on that.